All right, good afternoon, everyone. This is Matt Bieber from the New Mexico Department of Health. Thanks again for joining us for our regular weekly COVID update press conference featuring Acting Secretary David Scrace, Deputy Secretary Laura Patajon, and State Epidemiologist Christine Ross. As usual, the three of them will move through their presentation, after which we'll take questions using the raise hand feature of Zoom. So with that, I'll turn it over to our principals, and thanks everyone for being here.
Good afternoon, everyone, and welcome back. As you know, we're on a weekly schedule. Our press conferences vary with the case counts, and so we're having high case counts, and they're continuing to go up, but we want to walk through updates on vaccination, on what's going on with kids, because you had a lot of questions about that last week, and we're going to talk a little bit more about antibody treatment and hospital status and things like that today. So I think you're going to be seeing the usual suspects or the usual crew here for the near future, myself and Deputy Secretary Laura Patajon and our state epidemiologist, Christine Ross. And with that, I'm just going to turn it over to Laura to give us an update on our vaccination progress. Laura.
Great. Hello, everybody. Good afternoon. And yes, I'll be sharing the vaccine update today. So thanks to all of you in New Mexico, 77.6% of New Mexicans have received at least a first dose, which is amazing. 67.7% of New Mexicans 18 and over are fully vaccinated. And coming soon, we're going to be working on dashboard updates to reflect the additional doses that are being given. If you can see here on the right side, thank you, Brianna, for putting all the percentages of vaccinations across the state. And you can see the lighter colored is where you have less vaccination, and then the darker colored are where you have a higher amount of vaccination. Next slide. So one of the exciting things is that I think we did get a question that, you know, unfortunately, COVID has disproportionately affected people who are living in poverty. There's an index called the Social Vulnerability Index, which is a group of 15 indicators that include poverty, transportation, and crowded housing. 1 is the highest level of social vulnerability, and then 0.1 is the least social vulnerable areas. If you can see here in New Mexico, actually the higher social vulnerability areas have a higher vaccination rate. And that's thanks to all of you who've been helping out with vaccinations, have been really focusing on areas of high social vulnerability. So in New Mexico, if you're higher social vulnerability, you actually have a higher rate of vaccine uptake.
And Laura, I just want to mention we've gotten a question from Julia Goldberg about this phenomenon and whether we were tracking vaccination by areas of social vulnerability. These are large county level. It's possible to actually do it by zip code, but it would be really tough to read the graph if we had that many names and zip codes. Thanks.
No, thanks so much for clarifying that. Yeah, that's a really good point. Thank you. Next slide. So in terms of vaccines, we got a lot of questions about how are we doing for our kids. So you can see here that the vaccinations among young people for 12 to 15-year-olds, we're at about 40.7% of the population vaccinated. And for 16 to 17 years old, we're at 48.5. So that's pretty good. If you look at how we're doing, of course, we can do better, but that's where we're at right now for kids. Next slide. You can see our vaccine progress for ages 16 to 17-year-olds. Here you can see when New Mexico opened phase 2 distribution, allowing all people 16 and over to get vaccinated. So you can see that steadily climbed and continues to climb. So thank you for everyone getting their kids vaccinated. However, we just want to point something out, which is an equity issue that our team has been working really hard on, and also asking community members to work on this, community organizations. But you can see that for 16 to 17-year-olds receiving their first dose, people who are Hispanic or Latino, has the lowest rate of vaccination here. And then you can see Black or African American has the next lowest at 50%. and then white populations at a little bit over 60%. Our American Indian populations are doing great at over 75%. And then Asian Pacific Islander at about almost 100% here for 16 to 17-year-olds. So really, wanting to point out that although we have a higher vaccination rate overall, we also have to care and look at, some other groups that aren't being vaccinated. Next slide. This is for 12 to 15-year-olds. So you see the same thing when we opened up in May for 12 to 15-year-olds. A lot of people got vaccinated and steadily increasing, both the percent who are fully vaccinated and those receiving one dose. But once again, you can see the same trend of certain populations not being vaccinated as much, and especially really marked for Hispanic, Latino populations and African American populations. So what we think we might be seeing here is that some parents, maybe they are willing to get vaccinated themselves, but they have concerns about their children getting vaccinated. And so we really want to address people's common, the common misinformation that's out there, or concerns that parents might have in getting their children vaccinated, because as you'll see in the next slides that Dr. Christine Ross will be sharing, people who are unvaccinated are the people who are getting COVID, and kids who get COVID, they can get really, really sick. So next slide. So here's some common concerns and questions about the COVID-19 vaccine for children. So COVID vaccines are actually really safe for children. The FDA approved the Pfizer vaccine for 12 to 15-year-olds on May 10th. The Pfizer vaccine was studied in more than 2,200 children, and actually the clinical trial data showed the vaccine to be extremely safe and effective. They compared children who didn't get the vaccine against children who did get the vaccine, and children who were vaccinated did not, like in this study, none of them got COVID, while the children who weren't vaccinated did get COVID. Some people are wondering about why the approval for 12 to 15-year-olds take longer, and that's because there are more safety measures taken for studies in children. So next slide. COVID vaccines also do not affect children's DNA, or anybody's DNA for that matter. None of the COVID-19 vaccines alter or interact with DNA. The vaccines actually work by delivering instructions to our cells to start building protection against the virus, but does not affect the DNA. Next slide. Another question we've gotten a lot is, do vaccines affect children's future fertility? And so what we have found from the CDC is that there's no evidence that vaccines affect either fertility in children or adults. In recent in vitro fertilization studies, these are studies for fertility treatments, researchers actually compared success rates among 3 groups of women. So basically antibodies from those who have been vaccinated against COVID-19, those who have had recent infection, and then no antibodies from either having a recent infection. And the study found no difference in the pregnancy success rates among all these groups. So that's awesome. There's really no evidence for children being affected in their future fertility, or current fertility for adults for that matter. Okay, next slide. A lot of people are concerned that, well, my child already had COVID-19. Do they need to get a vaccine? And the answer is yes, because experts really don't know how long someone is protected from getting COVID after the infection. It is possible, even though it's very rare, to get infected again with COVID, even after you recover. And so a lot of people also ask, well, okay, so my kid got COVID, how soon can they get vaccinated? They can get vaccinated 10 days after they get the infection. So, yeah, your kids should still get the vaccine if they had COVID. Next slide. Another question is that, should I be worried about myocarditis or pericarditis in my child after a vaccine? Just so for people who haven't heard about this, myocarditis is an inflammation of the heart muscle, and then pericarditis is an inflammation of the lining of the heart. It's an extremely rare side effect. And they've done a lot of studies on this, and leading doctors, nurses, and experts from the ACIP strongly agree that the vaccine is safe for children. And just something I want to point out as a mom, obviously as a mom, I was worried about this too. And myocarditis and pericarditis is actually more common if you get COVID-19, and the risks to the heart are much more severe. So basically, you know, you're more likely to get that if you're not vaccinated. And those kids who did get, the very few who got this from after they got the vaccine, it was really mild. And basically you just do symptomatic treatment. You just take like ibuprofen and Advil, and that's how you treat it for these mild cases. So next slide. A lot of parents are worried about side effects. So like, should I be worried about side effects? And really, most people don't experience any side effects after the vaccine, but we also don't want to tell people like, oh, there's no side effects. It's really, there are some common side effects that really last only 1 to 2 days after the vaccine. So most people, about 85% of people, get like a sore arm where you got the shot. That's what I got, some pain, redness, or swelling. Some people, not as much, about 15 to 20% of people will feel like tired, headache, muscle pain, chills, fever, nausea, but it's very mild most of the time, and it doesn't last, but like I said, more than 1 to 2 days. And yeah, and then some people say with the second dose, it's a little bit worse. So so you can just expect that, let your kids know that. I think that's really important to kind of let your kids know what to expect. If you do get side effects, you know, you can reduce pain or discomfort by just applying a clean cold towel or wet washcloths over the area, use or exercise your arm, drink a lot of fluids before you go to get the vaccine. To reduce discomfort from fever, like I said, drink plenty of fluids, dress lightly, and then, you know, ask your provider or someone you trust about taking medicine like ibuprofen or acetaminophen over the counter for the discomfort. Next slide. Another question we get is, can my child get COVID vaccines while getting other childhood vaccines? Because like, you don't want to be driving twice to get your kid vaccine. And the answer is yes, you can get the COVID-19 vaccines and other vaccines during the exact same visit. A lot of the new data shows that our bodies develop additional protection after getting vaccinated, and the side effects are really the same when given alone or together. So really get your kids vaccinated. It's really important. Next slide. The CDC also found that fewer child vaccines were given during the COVID pandemic. So really just reminder to all the parents out there, get your kids vaccinated, protect your kids. When we protect our kids, we can also protect them from getting a bad COVID side effect, but also the rest of the family as well. Next slide. We had another question, which was like, what is the difference between additional doses and booster doses? So a lot of people are talking about the third dose, who gets it? So we just want to make sure, we want to kind of call it the additional dose. The purpose of that additional dose or the third dose is to help build an effective immune response against severe infection and death for people who are immune compromised. Those are people who didn't really mount a good response to the vaccine. So we're giving them a third dose to help them mount that good response. When can these people get a shot? So if you're immune compromised, you can get a shot at least 28 days after your second shot. And then what's the difference between that and the booster dose? So the booster dose purpose is really to boost immunity from what's normal with many vaccines, is that you get waning antibodies from the vaccine. So you need to boost the immunity. Who qualifies? No one yet qualifies for that booster dose. And then when can I get that shot? We're still awaiting final data and recommendations from the CDC later this month. And as soon as we have it, we'll let you know what to do next. So thank you so much for letting me share this update on vaccines. And I'm going to turn this over to my amazing colleague, Dr. Christine Ross. Thank you.
Hey, thank you, Dr. Petahon. It's my pleasure to be here today. As always, though, I wish I had better news to share. I'm going to be sharing some of our epi data. I think I have about 7 or 8 slides. So this is an epi curve, or what we call an epi curve, when we plot the new cases by time or by date. And then you can see the number of cases, which is on the y-axis. The x-axis, or that bottom line, is time. And so the big mountain in the middle represents the winter surge of cases that we had. And over to the right, you can see this surge that we're in now. We hope that we are seeing the semblance or the beginning of a possible plateau, though it's too early to say that for sure now, but we have seen a deceleration in the number of new cases. But again, it's too early to say, and we hope that we'll have more information next week. So next slide. So this is a slide from LANL. So LANL uses the state's epi data, and they use this to make mathematical models or projections on the number of cases, hospitalizations, deaths, and this helps us at the state to aids us in our planning and management of the impact of the pandemic on New Mexico. So they've projected that daily cases should hopefully peak soon. And again, this coincides what we're seeing in our epi data, which I just shared in the slide above. But we all need to continue doing our part with all of the mitigation measures. So masking indoors, avoiding crowds, every eligible person, please get out and get a vaccine, etc. The graph is actually projecting what we might see with hospitalizations. And if you look there on the x-axis or time, which is plotted out on the bottom line there, they're projecting that we could possibly reach the need for 770 beds, or over 700 beds could be needed by COVID patients alone by next week. So this is really, really important information, and we've been using this information to try to plan accordingly to be able to manage this influx or volume of patients as best that we can. So Secretary Scrace will be talking more about hospitalizations next. So next slide. So when we look at what's happening in the state, we look at geographically where we see different case rates, test percent positivity, and we put this in a report called Levels of Community Transmission, which is posted online. The information you see on this slide is actually an epi curve, or again, it's the plot of cases that we see over time, and this is by region. The left is the Northwest region and the right is the Southeast region. And what you can see here is a very striking difference in the number of cases. We're currently experiencing quite a surge of cases in the Southeast. And what's interesting here is that it correlates what we see as this pattern or relationship between highest case rates or burden of infections being in areas where we have lowest vaccination coverage. So you see the box on the left there is indicating that we have over 66% of persons 18 and over fully vaccinated in the Northwest as compared to 45.6% 18 and over fully vaccinated in the Southeast. So next slide. And so this is some of the data that we shared last week. This is our surveillance data where we look at cases, hospitalizations, and deaths, and we look at this by vaccination status. What you see here is data that encompasses the previous 4-week period. And really the take-home message is that the majority that we see, again, of cases, hospitalizations, and deaths are among persons who are unvaccinated. Next slide. And this is data that we're sharing in response to questions that we've received over what do we see over time, or what does the trend look like over time. And again, I think for the sake of time, I'm just going to go straight to the take-home message, which is that the majority of infections that we're seeing is among unvaccinated individuals. And this is what's driving this current surge of cases that we're seeing, in addition to this highly infectious Delta variant that we're dealing with. Next slide. I wanted to talk a little bit more about who do we see getting infected. So we talked a little bit about geography, and I referred you to our county level report, which is posted online. And then this is in reference to demographics. And so I just want to point out that case rates, again, this is the mountain. The mountain in the middle is the winter surge, and then off to the right is what we're seeing now. And you can see that case rates have increased among all age groups. But what we're seeing currently is the highest case rates among 5 to 17-year-olds and also 18 to 34-year-olds. And most critically, we know that this includes many children who are not eligible for vaccination right now. So it's really important that everyone around them, everyone that's eligible for vaccination, seeks out a vaccination. Okay, next slide. And again, just diving into this a little bit more, we wanted to talk about cases among school-aged children. And so the first graph that you see here is 0 to 4-year-olds, and you can see that uptick there. But overall, 0 to 4-year-olds make up a very small proportion of our cases. But we want to show you this trend, which is this uptick. And then the graph below the 0 to 4-year-olds is 5 to 17-year-olds, and you can see this very dramatic uptick in cases that we're seeing amongst that age group. And then over to the right, we just look at the proportion of cases that are among these different age groups. And I just want to draw your attention to the yellow line, and you can see that our 5 to 17-year-old line there is growing. So they're becoming a growing percentage or proportion of our total cases, though older age groups still make up the predominance of our cases. And you can see the pink is 35 to 64-year-old and the blue is 18 to 34. I want to mention that given the very high levels of community transmission of this virus that we're seeing currently in New Mexico, it's really difficult to discern where or to pin down one specific exposure that led to a specific infection. So in other words, children have multiple possible exposure events that can happen in the community, but could also have happened in school. And we know that in school, we are bringing large numbers of unvaccinated individuals together in a close environment. So we want to emphasize the importance of mitigation measures, how important, critically important, layering different mitigation measures in school is. I also want to mention that we're working closely with our public education department. We want to work on collecting better data to help us discern school-associated cases amongst children versus kids who are getting infected outside of the school environment. So next slide. And we wanted to mention test percent positivity and how the fact that we're seeing quite high numbers among school-aged children. So you can see that this is broken down by age, and the cumulative test positivity is over at the right. And the take-home message for me is I really hope we can see more testing of these age groups because there's clearly more infections that we're not detecting at this time. Testing is extremely important tool because it helps us it quickly leads to isolation of infected people and then quarantine of contacts. So the key is we want to stop onward transmission of this really highly infectious virus. So I think the next slide is my last slide. And I wanted to share this publication, and just again to emphasize that we're really trying to be careful in our school settings and mitigate the risk that we find there when we're bringing kids together. And so this is a study, it's an outbreak investigation from Marin, California. And what they showed here was it was an elementary school, and I think 23 out of 25 of the teachers were vaccinated. They also had other mitigation measures in place, such as physical distancing, masking, etc. But unfortunately, the teacher, which is often common, thought that she or he had allergies, thought that some of the symptoms that they started to experience were not related to COVID. So they continued coming to school teaching. While in the classroom, there was intermittent use of a mask by this teacher. 2 days later, a test showed up, or a test result was available, which showed that indeed the person had COVID. At that point in time, there the whole classroom was exposed, and 12 out of the 24 kids in that classroom ended up testing positive for COVID. And so this just sort of exemplifies the importance of vaccinating all eligible adults, including teachers, so that we can protect the population that is not eligible for vaccination, and also just the importance of the need to mask properly and to follow all other mitigation measures in schools that we know work. I do want to point out that there weren't any associated hospitalizations and deaths, and again, children are quite resilient and tend to do fairly well as compared to adults. So I think I'll end there, and I'll turn it over to Secretary Scrace now.
Thanks very much, Christine, and also thanks, Laura, for the excellent information today. I'm going to do an update on hospitalizations and some news on deaths as well. The question came up before, are we seeing a rise in hospitalizations in New Mexico children? I just saw something on the news this morning about increased hospitalization rates among children across the country, but those two lines on the bottom, the Halloween colors of orange and black there, are pretty flat, with just a very small 0, 1, or 2 kids in the hospital at any given time. So we are not seeing that rise, and we're not sure why we're not seeing that rise yet. It could be that we have a better than average vaccination rate, so the vaccinated people in the state are providing more protection for young people who don't have the opportunity to be vaccinated yet. I like to think that that's one of the things we're doing when we all get vaccinated. But so far, with respect to kids, and we're focusing on kids today, we're not seeing that uptick in hospitalizations. Next slide, please, Brianna. However, we still are quite tight in terms of hospitals. This is our system capacity that hospitals, our hub network evaluates themselves every week, right on that line between our highest level of contingency and crisis standards of care. And we evaluate this multiple times during the week. We do the measurement scale once a week on Tuesdays, and we're still very, very close, as you can see here, right on the line between orange and red. And our transfer center continues to run, continues to move people around the state to try to get people into whatever hospital bed is open. I believe the next slide will show where those open hospital beds are. There are 30 total ICU beds as of yesterday morning. Most of those, again, get filled during the day, but hopefully some people move to a lower level of care to make room. 39 beds available around the state. Those inserts in the lower right on both give you a bigger sort of blow up of the Albuquerque metro area. And if you're familiar with those facilities, you can figure out which ones are which, but still very, very tight when it comes to hospitalizations in the state. A little bit of room down in Las Cruces, very, very full in the Albuquerque metro area. And then just that one hospital, the UNM hospital out in Sandoval County, Sandoval Regional Medical Center recently opened up some ICU beds. Still very, very tight. Keep in mind that we already have all of the actual beds full. And so these are stretch beds where we've converted areas and we still have some room there, which is good, but very, very tight statewide. Next slide, please. And then unfortunately, I think we all know that hospitalizations follow, the case counts by a couple of weeks, and that's a problem too. Christine showed you that hospitalization projection. Even though we might be seeing the beginning of leveling off of cases, it's not so much cases are coming down, but that rate of increase is declining. It's decelerating, if you will. We are still, going to have a couple really rough weeks for hospitals, even if things do turn around with cases. And as usual, about 6 weeks after cases start going up, deaths also start going up. We had 26 week before last. There is a lag. We do get deaths reported later on, sometimes from out of state. Sometimes the medical examiner is doing an evaluation, but we're still apace with keeping up with entering them all into the system. And we don't enter them by the day that we got them. We enter them by the date of death. So you'll see some of this being backfilled, and we'll probably show this curve for another 4 weeks or 5 or 6 weeks. And you'll see these numbers change from week to week as we get further information in. One death is too many deaths. I think those of you who have been following the regular reports know that we're now seeing 3 or 4 some days, and hopefully, the projections are that could go up to 6 or 10 or as high as 15, but hopefully we will see that level off again soon. Next slide, please. I wanted to take a little bit more time to talk about treatment today. It's kind of funny because a friend of mine just texted me that she had just gotten COVID and she has a couple of risk factors, and I was just texting her back that she really needed to call her system and get antibody treatment. And so on the next slide, you can see that the monoclonal antibody treatments have been in place for many, many years for cancers, autoimmune diseases, even dermatologic conditions. And what happens is our body makes these antibodies to fight infection. And those antibodies, as you can see in the diagram, those green sort of 3-leaf clover sorts of things are attaching over there on the right to the COVID virus. And the more of those little red bumps on the virus the antibodies can block, the less likely that virus is to attach to a human cell and get inside the cell. So the idea with the monoclonal antibody treatment is you get a hold of all of the coronavirus in the bloodstream and attach these manufactured antibodies to the virus so it diminishes the seriousness of infection. And I've said this a million times, and you're probably sick of it, but remember that in people over 65, people who are obese, who also have symptoms or symptoms plus any risk factor, the risk of hospitalization can drop by as much as 75%. So for every 4 people who have symptoms plus risk factors who get the monoclonal antibody treatment, 3 people who otherwise would have been admitted would be kept out of the hospital. And so the key is who otherwise would have been admitted, because the hospitalization rate runs about 8%. Nonetheless, it's worth getting the treatment. I would certainly get it if I got COVID, and now there's a new way to get the antibody treatment where you don't have to have an IV. They can just give you an injection and it's absorbed and treats the virus as well. And so we're working on expanding that throughout the state as well. On the next slide, you can see an antiviral agent, remdesivir, on the left, and that use in hospitals, and that's for moderately ill people who are in the hospitals, gone up quite a bit. And then on the right, a couple different kinds of monoclonal antibodies, although mostly we're using Regeneron. And I just saw the data from this week. It just came through like 10 minutes ago, and we're up even higher, which is good, but still would love to see more people treated. These are weekly numbers, not daily numbers. You really should think about getting treatment if it turns out that you are infected with COVID, you have symptoms, you're obese or over 64, or have another risk factor for serious coronavirus disease. Next slide, please. I wanted to show you something that we've been thinking about a little bit. On the left, you can see the slide that Brianna so patiently put all the statistics in for each county on the percent vaccination rate. But remember that it's not just the percentage vaccination rate, it's really the number of unvaccinated people. The more unvaccinated people you have, the more opportunities the virus has to spread from place to place. So really, we have more unvaccinated people in Bernalillo, where we're still seeing a fair number of cases, but reasonably under control right now, than we do in all of the southeastern part of the state when you add those counties together. Doña Ana County is next, then Sandoval, then San Juan. And so we still really want to encourage people in Bernalillo County and of course throughout the entire state to get vaccinated. It's the best way to prevent serious illness, hospitalization, and death, but it also helps to prevent the spread of coronavirus in the state. Next slide is, I want to talk a little bit about testing today too. We've had some calls from people who've had trouble getting testing or want testing or want to know more about who's doing the testing, and some reporters in that list as well. So we've got some additional data today for you that I don't think you've seen before. This is our test positivity rate. It was going up, as you can see, above our new target of 7.5 for the past month or so, and now it's starting to trend down and really just hugging that 7.5 line. It was 7.6 yesterday over a 7-day period of time. Usually that test positivity coming down is one of the early warning signs that we might be starting to flatten the curve. Particularly worrisome though is and I didn't know this until today, the high test positivity rate amongst kids, which means not enough children are being tested. And we really need to, this is a shout out or a call out to all parents watching today. You know, those symptoms of what you think might be allergies or just a runny nose or a mild cough, you really should have your child tested because at least during a pandemic, the chances of it being COVID are pretty high. Next slide, please. So here are all the labs in the state, I think not in any particular order. And the two in-state labs are in the middle there, SLD and Tricor. And you can see they're doing pretty well. Between the two of them, they're doing exactly 20% of all the testing in the state. Go back, please, Brianna. And their turnaround time is a little more than a day, about 1 day and 6 hours from when that swab is obtained. Curative, another big testing operation that's really helped out New Mexico. You can see just in the past week, did over a quarter of all the testing, and their turnaround is a little less than 3 days. Remember, they have to FedEx theirs out or UPS them out. And in any case, but they're still, given the fact they have to ship out, a good option. Vault also, you can see there, another fairly high percent. This is the one you can do at home. They'll ship you the tube. You can just drop it off right at the UPS. That has to be shipped as well. And we're actually recommending, and I think you'll see this in a coming slide, that if you're one of those folks that has to get tested once a week because of your work or you work in a congregate setting or because you are unvaccinated and it's required in your work, we recommend Curative and Vault as good options. And that leaves more room for the other testing sites. LabCorp, Quest, two other big labs. Pathology Consultants, also a New Mexico lab, and Roswell has done a lot of our testing as well. And so on and so forth. Someone asked what other was, and other consists of about 200 other places like doctors' offices, some hospitals that independently run the tests. And so that's the sum of all of those tests. And you can see It's almost 30% of all testing is done in other smaller labs. We do track and trend, turnaround time. If it's going up, we give folks a call and encourage them to get that time lowered. Next slide, please. So kids and adults, please get tested for COVID. If you have COVID-19 symptoms, which we've listed for you here, remembering in kids, gastrointestinal symptoms more common than in adults. So just even a tummy ache, believe it or not, in a child who doesn't normally have that, it's a good idea to get a COVID test. If you're unvaccinated and you live and work in a high-risk congregate setting, you're probably already required to do these, at least the 3 listed there, as well as in some other facilities. Now long-term care actually requires everyone to be vaccinated. If you don't have symptoms, we're in close contact with someone, and this has changed. So even if you're vaccinated now, if you've had really close contact, we really encourage you to get a test as well. And usually the best time is about 5 days after the contact period. And lastly, if you're a patient that's scheduled for a procedure, although there are not a lot of elective procedures going on in the state right now, you may be required to have a test before you have a major surgery. And that's really for your protection and also for the protection of your surgical team. Next slide. We have been getting calls from folks saying, hey, I'm having a really hard time getting a test set up. Can you help me? And remember that all you really need is a computer or a phone to do this. And you type in findatestnm.org. And what I'm going to do here is share my screen. And what I did was I clicked on that link. And can you guys see my screen here now?
Looks good.
Okay, great. And so what I can, let's just say I want to get a test. I can just type, I live in Placitas. I can type my zip code in there. And I can filter by a given city. I'll just look. I want something open today. And here you can see Vault. I can just do it at home. So if I'm not in a hurry, if I'm just doing screening testing, a great option for me. One in Santa Fe I could drive up to. Another one a little further away because I asked for all cities. I could go down to Albuquerque, Las Vegas. But let's just say I decided I want to get an in-person test and I don't want to drive that far. Let me just put in Bernalillo, which is right near my house. I know there's not a testing site in Placitas, and here's a curative site just down the road from me. I could go. They're open until 4, so I still have a little bit of time if I wanted to do it after the press conference. But as you can see, you can go in, and then if you want to go ahead and schedule the test, it depends. There's a link here, so I could just go to the curative website and fill out and book now and fill out a location. So I'm going to now stop sharing my screen and go back to you, Brianna. But I just want to show you how quickly that could be done. And if you can't do it yourself, give us a call. We're happy to help, but it is a fairly rapid process to find a place. And I did it on the computer today. I've done it on my phone as well. Okay, next slide. And then lastly, I just want to mention too, not next slide. We already talked about, we suggest Vault and Curative if you're just getting surveillance testing. You could do it, you need it once a week and it's due on Friday. You could do it, every Friday for the next week or Monday, and usually have your test results back. So Vault, you can do at home. Curative, you can do at a site near you if there is one. And then also for people with symptoms, there's that other category. There's an awful lot of places around the state, and even pharmacies do the testing. And even now, some reasonably reliable over-the-counter tests are available if you want to do that. if you're having symptoms or been exposed. If the test is negative and symptoms persist, you may want to get a PCR test, however. Okay, next slide. I think we're on the home stretch. We've been showing a slide every week of somebody who, actually died or became severely ill. And this is an unvaccinated California nurse who you can see on the right. And she and her husband, you can see on the left, upper left there, were both admitted to the hospital, just a few days apart in August. And the nurse, Davy, on the right, died. And she hadn't been vaccinated. She was concerned about her pregnancy and getting the vaccination. The baby was delivered. Her husband is still in critical condition. And her brother-in-law, Davy's sister, just said, about Davy's wife. He was trying to breathe. And I said, if anyone is not vaccinated, I suggest you do so now. And so don't let this be you. This current surge we're seeing isn't actually a necessary surge. It's the result of it's raging amongst unvaccinated people. We understand this is America and that everybody has a choice, but there are other folks as well. There's hospital workers and others who are really struggling right now. So please reconsider your vaccination decision. Please talk to a trusted healthcare provider. Please think about getting vaccinated and get vaccinated. And last slide, just a reminder, this virus is changing. Get tested if you've been exposed. And if you have COVID-19, don't forget the monoclonal antibody treatment. We'd really like to see more people getting it because it keeps people out of hospitals. Our case counts are still way, way too high. And so keep those hands clean. Don't cough into your hands. Wear your mask indoors. Remember, masking is required outside your home. Keep your distance from other people. Don't forget preventive healthcare and don't forget that vaccine. And with that, I'm going to invite Laura and Christine to turn their cameras back on, and I think we're open for questions.
Great. Thank you to all three of you. And I see some hands going up. I also see some new names that I don't think we've had with us before, so welcome. Just a quick reminder for the press corps, when I call on you, we'll put 3 people in a row, a couple of people on deck. And when it's your turn, please just do identify yourself, including your outlet. I also did want to offer a quick thank you to the press. Last week, we had requested that if you had a specific epidemiological question, you send it in advance, and several of you did that, which enabled us to have a really rich conversation and prepare more fully with Christine and our full epidemiology team. So that was really helpful. I appreciate that. And then one final reminder, last week we had said that we would likely shift away from just going through the list once, because what folks were understandably tending to do was cluster 4 or 5 questions, sometimes unrelated, into one, and it was a little difficult for our principals to follow sometimes. So I think what we'll do this week is please just do ask one question when you're called upon, but we will go through the list more than once if we need to ensure that all the questions get covered today. So with all of that, thanks very much. Our first 3 questioners will be Matt Grubbs, Julia Goldberg, and Stella Sun. Matt, you should be unmuted.
Great, thanks, Matt, and thanks everyone else. I was wondering if you have a number for the number of medical workers subject to the vaccine mandate who have quit or been fired or furloughed since that mandate went into effect. There are a lot of people wondering, and we've heard 4 or 5%, but I haven't seen any actual numbers. Thanks.
Well, that's a great question. And I just asked that same question of our hospital group on Tuesday. They said that they had heard reports of people quitting. And so I said, can you give me some numbers? And Mike Ciccarelli from UMM said, yeah, we asked for some numbers because we knew you would ask us for numbers. And so we don't have those numbers yet. I do have one set of numbers that I think is revealing and interesting. It's from Unity Point, which is a system in the Midwest. I know they're in Iowa and Illinois and one other state. They have 30,000 employees. They instituted the vaccine mandate in May. of this year, 2021, and only 150 people left or quit as a result of that, which is 0.5%. So I think it's the tendency to focus on this small group of people. I know in our conversation with the hospitals on Tuesday, they said there was a mad rush on the very last day of people who realized they wouldn't, actually be able to work again the next day. And so, but we don't have the numbers yet. We have asked for them, and we are starting to collect, actually, Matt, the data from every hospital, total employees, fully vaccinated employees, partially vaccinated employees, exemption employees, and unvaccinated employees. And so hopefully we'll have some preliminary data on that next week. It might not be a bad idea to actually collect people who've resigned as a result of the mandate as well. And so that's a good idea. I hadn't thought of that. So I will add that to the list. Thanks.
Thank you so much. Next, we'll turn to Julia Goldberg, followed by Stella Sun, and then Dan Boyd. Julia, you are unmuted.
Thank you. This is Julia Goldberg with the Santa Fe Reporter. I guess I wanted to follow on my question about the cases within the poverty census tracts, which Dr. Space, you had shown a lot during the beginning part of the pandemic, both cases, hospitalizations, and deaths. And so when Dr. Petahon shared last week or the week before the high rates of vaccination in the areas with high social vulnerability index, I wanted to see if that indicated that there had been a drop then in the high poverty census tracts. I don't know what the overlap is between the two criteria, but I assume there's a lot. The health and social indicators report looks to me as though cases by poverty level started dropping a little bit at the start of August, but there's no dated for poverty census tracts for hospitalizations and deaths. So my question is just, is in fact that having that effect where there's fewer cases, fewer hospitalizations, fewer deaths in areas with high in the poverty census tracts as a result of that work for vaccination? Hopefully that makes sense. I have another question, but I guess I'll get back in line. Thank you.
Yeah, I'm going to start, Julia, because I read your question, but I think as you explained it, I understood it better. So I think you're referring to this report about socioeconomic status, and I'm doing the math in my head, but this is about, so this is census tracts grouped by poverty rate, and on the right, you've got census tracts where 40% or more of the people are living in poverty and less than 5% here on the left. And we've been following this ratio from the very beginning, which you can see today is a little bit more than 2 to 1. I'm guessing it's maybe 2.1 to 1 or something like that here to here. And but if you remember, like in March and April, when this first was reported, this peaked at a 10 to 1 ratio. And I think part of what actually happened is that, of course, there are more infections over time, but the higher income census tracts caught up a little bit. But we're still seeing that hospitalization and death rate, at least nationally, at about 2.5 times the rate in a high poverty census tract than in a low poverty census tract. And Christine, I'm not sure if that's something we track in trend or not. Yeah, we do. So again, to your question, Julia, the black line on the bottom, and these go pretty much by census tract, is high income, and I'm not very good with colors, but the green line up here is low income. And over time, you can see, in the best of times, the ratio gets pretty tight and they're very similar. And in the worst of times, during the peaks, there's a much wider spread. And some of this we've talked about before can have to do with people's ability to stay at home. If you're an essential worker with a lower income, you may be in this, live in a lower income area. You have to do your work. You have to come in contact with more people. So I don't know if you have anything else you want to share, Laura, about it, but I do know that we're tracking. We've had success with the vaccination, but I don't know if there's anything else either Laura, you or Christine want to add. Lori, you're on mute.
Add that our work isn't done yet, right? There's still a lot of people we want to vaccinate in high social vulnerable zones and also with racial ethnic equity issues as well. But I think it's a complex problem because I don't think we can say just because you're vaccinated, you may, just because you're vaccinated, like how that relates to hospitalization and death, you're going to be less likely to get hospitalized or die if you get vaccinated. But I think, there's a lot of distrust, right? And concerns in areas of high social vulnerability. So I think it's up to us to keep on working to answer people's questions so that we can get more and more people and reduce those health disparities. So I think you're right in the sense that we are improving and we have more vaccinated people in social vulnerable areas, but there's still a lot of people to go. So we want to keep on working on that, and our team is actively working for that.
Great, thanks to you both. And next we'll turn to Stella Sun, followed by Dan Boyd, followed by Jackie Kent. Stella, you should be unmuted.
Good afternoon. Thank you so much for hosting this. And thanks so much for sending the breakthrough case data, which is what my question involves. So just taking a look at the data, it appears since February, there have been 6,000 breakthrough cases total. And in the last 4 weeks, if I'm reading the data right, it appears that 3,500 of those happened during the month of August, so last month. But it looks like with more than 1 million New Mexicans who are fully vaxxed, the breakthrough cases are very rare. I'm hoping you guys could address the likelihood of becoming a breakthrough COVID-19 case if you are fully vaxxed. Thank you.
Christine, do you want to start? I can bring up your report if you like.
Yeah, sure. You're quicker at that than I am. Yeah, I just want to say I think you're absolutely correct. The rate of for a vaccine breakthrough case is very, very low. I don't have the rate in my head. We could share that, but it's extremely low. I think that our report does, I think you just mentioned that the report does show that there has been an increase in the number of vaccine breakthrough cases seen over time. So we're seeing more of these vaccine breakthrough infections during this current surge. And this is a complex issue. It appears that it's most likely related to the fact that Delta is extremely infectious, and community levels of viral transmission are very high. It's also not clear if there's, mixed into that group or people that didn't have a great response to the primary vaccine series. And this is similar data was used to recommend the third dose for the Pfizer vaccine, because I think there have been some other studies that have demonstrated, so outside of surveillance data, we've seen that a good number of these vaccine breakthrough cases could in fact be folks who are immunocompromised. So they really didn't respond well to the primary series. So that's why we are trying to roll that out as vigorously as we can to get those folks in that qualify for this third dose to come out and get it. The other thing I want to mention, which you don't see in our report, but we're trying to triangulate this with other data, is that there is evidence that a large proportion of these vaccine breakthrough cases are really mild. So I think the take-home message is the vaccines do remain highly effective at preventing serious outcomes. So highly effective at preventing hospitalization and death. Let me pause there, see if Secretary Screese wants to add more.
Yeah, Stella, hi. I think I'm really intrigued by this part here, which we're not supposed to talk about, right, Christine? We're not supposed to talk about what happens in the gray area because we don't have complete data. But, we saw this, we were worried about it, but it doesn't make sense to me that there would be a difference in reporting in vaccinated versus unvaccinated people. So the lower this one goes, the higher this one goes, because they both add up to 100%. But this gets you back up to a 20-to-1, or 19-to-1 chance of getting COVID if you're unvaccinated versus vaccinated. So we debate this and try to figure out what it means. In the next couple of weeks, this gray bar will move over and we'll be able to talk more about what's going on there. But if you're worried about in vaccine breakthrough infections, there's a ton of stuff you can do. Wear your mask, keep your distance, avoid indoor settings that are high risk or where other people have their masks off. I've been in a couple indoor settings and people, my motto is when people start taking their masks off, I just take off, I just leave because it's just not safe. And so we can all still protect ourselves. We can't always be responsible for whether other people protect themselves. Presbyterian did a survey that this is not earth shaking, but showed the people who were determined not to get the vaccine were also, determined not to wear masks. And so there was a pretty high correlation between not being vaccinated and not wearing masks. And both of those, unfortunately, even though they are personal freedoms, are high-risk behaviors right now. And so I think there's still a lot we can do to prevent breakthrough infections. But, really, it's the same stuff we were saying back in March of 2020. And interestingly, it's the same stuff they were saying back in 1918. Wear a mask, keep your hands clean, keep your distance from other people during that big pandemic for influenza.
Thank you, everyone. Okay, next we'll turn to Dan Boyd, followed by Jackie Kent, followed by Vincent Rodriguez. Dan, you are unmuted.
Yeah, good afternoon. Dan Boyd with the Journal. Thanks as always for the opportunity. I wanted to ask about herd immunity, which is, obviously an issue that's come up over the last year, and countries have taken different approaches to it. Wanted to get your thoughts about with the increased vaccination rates here in New Mexico and the number of recent cases we've seen, whether we might be approaching herd immunity or if that's still likely to be elusive, given the different variations of the virus and things like that. Thanks.
Yeah, I'll say a little bit, but then Christine will say most of it. And, we spent I think, right when the vaccine came out, we had this spreadsheet to calculate what percent of people are partially vaccinated and fully vaccinated and had COVID, and deduplicating the vaccine people from the COVID infection people and calculating these percents. But in the midst of our enthusiasm, I think the national sort of scientific view on the concept of herd immunity disappeared. And probably most people feel like COVID isn't the sort of thing that there's a certain vaccination rate, like 70%, where it just dies out. And particularly when the whole world isn't vaccinated and people travel, it's kind of a challenge. But we do have our lead epidemiologist on here, and feel free to correct me if anything I said so far, Christine, was wrong.
No, I don't think you said anything wrong. I think it's a really complex topic, and I think what you said is accurate, that we're not really sure that there is a sort of magical number that we can reach and where, life is going to return to normal. And I think what Secretary Scrace said was really important, that this is a global pandemic, and New Mexico is not an island. We're part of the United States, and we're part of this global community that is really, really well connected by air travel, sea, land, etc. So I think that I don't think that there's a specific number that I can quote, and I think that we will be dealing with this for a while. But the most important thing is that we have now unlike what was happening, a short while ago, we now have a really highly effective countermeasure to fight this pandemic, and that is vaccination. So I don't have a specific number. That's why every week we're making a plea that every single eligible person please seek out a vaccine. Our healthcare system is being extremely strained right now. It's just heartbreaking to see what's happening, which is so we're at a very different point in time now that we have this effective tool in our tool belt, so we want to use it. Let me pause there. I'm not sure if I answered your question exactly, so let me know if I didn't.
Okay, well, we can always circle back to Dan as well, Dan, unless you want to pipe in now. But I think otherwise we'll turn to Jackie Kent, followed by, sorry, I think we may have, sorry, Jackie Kent, Vincent Rodriguez, and then Brittany Costello. Jackie, go ahead.
Hi, good afternoon. Thank you all for your time. My question is about increased COVID testing or more people getting tested. In addition to Dr. Grace's earlier point that you suggest vault and curative tests for people just getting surveillance testing maybe once a week, is the state looking at other solutions for people finding it almost impossible to get a same-day COVID test and even lower those turnaround times? We're hearing that it's difficult for many families who can't get childcare or take days off work. What are your solutions? Can our state labs do more testing? Can the state provide more testing sites? What do you recommend? Thank you.
Yeah, I'll start with that one because I'm on testing today. I was going to put this slide in when we showed to the governor yesterday, but this is just, and hopefully you can see this graph, but it's, oh no, you can't yet, just a second. Now you can see the graph, yeah. This is just testing way back to June, and you can see we've ramped up really, really nicely. In the past week or so, we had a low of almost 11,000 tests a day, a high of 20. I think that was part of the reason that there's still places with open spots along the way. I think the more that folks can use for surveillance testing, some of the mail-in options, curative and vault, that frees up some of the sites online. Also, please use the website, and we're happy to help people who don't have a computer, who don't have a phone, but we don't think we're at our testing capacity in the state lab. SLD Tricor still has more capacity to do tests, so we're doing what's coming in. We just need, as you saw, more kids in particular to get tested, and then of course any adult with symptoms or who's contacted someone or has reason to be concerned that they may have COVID vaccinated or not. So I think we're responding pretty well, and I think there are people, and I hear about them too, that say, hey, how do I get tested, or I can't get tested, and I just talk on the phone with them, like my friends, and go online and show them how to do it. So for the most part, there may be some limits or a day wait, but for the most part, we think we're keeping up. Thank you.
Great. Next, we'll turn to Vincent Rodriguez, followed by Brittany Costello. And then I may just ask, I think we'll probably turn back to Julia Goldberg at that point, because I think she was looking to ask a second round of questions. And if others want to get in line after that, then you're welcome to raise your hand again. So Vincent, please feel free to ask your question.
Hi, this is actually Maggie from KWT. I am calling on Vincent's line. I'm going to follow the question about testing. I just went to the site that Dr. Grace mentioned, and I could not find a test. Presbyterian just says no appointments available at this time. DOH says none till Friday. First Nations is only testing on Tuesday and Thursday. NextCare doesn't even have a place to book a test. Passport will get me in tomorrow. CVS, nothing. I went to Monday, still nothing, and I finally just stopped. I know that we have an influx of testing with kids being back in school, with a lot of people that are unvaccinated being tested once a week. But I do think that even though I hear Dr. Scrace is saying there are tests, we see people looking for them and unable to find them. At the beginning of the pandemic, we had, I think one of the places the state really excelled was that we had so much testing, and now that really doesn't seem to be the case. And I'm wondering if the state is looking at, you know, maybe even with this information, figuring out a way to heighten the tests the way that they did at the beginning of the pandemic, so that we can, you know, fill the need that is so clearly there.
So now that they are mandating the mask, I'm not sure.
Sorry to
Someone
interrupt.
needs to mute.
Is on the line and unmuted. Could everyone just mute themselves unless you're Maggie? Okay, thanks.
Yeah, Jackie, I understand what you're saying. I think we are doing the best we can. The National Guard's still working with us on testing. We've extended their time as well. I think the key to what you said was, even though you listed off 9 places that you can't get tested, you can get tested tomorrow at one of them. And that's sort of the point, is you listed one where you were able to get tested. And so we're not trying to create a situation where there's 100 openings every day at every location. You know, we're still using our public health workers to get vaccinations and do a lot of other good work here. And so we are trying to keep up. But again, if people have trouble getting a test, they're welcome to call the DOH testing line. It's available online, and we can walk you through that process. But I don't know how far that test was. And then if you know, go to Vault, you could get a test as well. Remember, you have to test and then stay quarantined until you have the test results back. So that might be a little bit longer, but I understand that it may not be as convenient. We're putting every resource that we have to the testing. And in your case, when you did the search, you were able to find a test tomorrow.
Thank you, Dr. Scrace. Next, we'll turn to Brittany Costello. And then I'm actually going to ask Julia to wait just a moment, because we've got Morgan Lee, who has not asked a question yet. So we'll go to Brittany, then Morgan, and then I believe back into our second round for folks who've already asked questions. So Brittany, please feel free to ask your question.
Hi, thank you guys so much for your time as always. I wanted to, I know we've talked about this before, but as time goes on, I wanted to just bring it back up. I'm wondering about the immune response from the vaccine. Again, how long does that last as we go on in this pandemic? I know initially we were hearing the 6 to 8 month time frame. Seems like we're getting kind of close for maybe some of those people who were eager to get the shot early on. So I wanted you to talk a little bit about that. Thank you so much.
Yeah, I'll start, and Christine will follow up, because I know she's been on the CDC calls where they've discussed this. I think that I really still think the answer is we don't know for sure. We do see a slight decline in circulating antibodies in the blood that comes down over time. And those were some of the studies that started this idea of giving everybody now it's called a booster, right? A booster vaccine, or a third dose after the initial, some people say 6 months after the initial vaccine. Some people say 8 months. If it's 8 months, I'll be due for my booster in another 2 weeks. But I think there's a big debate going on about this, and whether the breakthrough cases in vaccinated people are really because immunity is declining somewhat, or are they because this Delta variant is so vicious and spreads to so many people? So Christine, and then I know Laura, you might have a comment on this as well. So
I don't think I have anything major to add to this. That I think that as Secretary Scrace said, that we just don't know yet. And so I think that this is being evaluated on an ongoing basis. I did attend a recent call, one of the White House press briefings, where there was a discussion about what do we know from the immunological data. And I mean, we know that antibody levels decline over time. That's a fact that I think we all agree with. We believe that higher levels of antibody may be required to fully protect against those vaccine breakthrough cases we're seeing with Delta. It's not clear. Again, it's not really clear. And we also know that when you give a booster of a messenger RNA immunization, you give a third dose, it increases antibody titers by at least 10-fold. So this is what this is the data that folks are looking at, which is supporting this idea that a third messenger RNA immunization is going to be needed to increase the level of protection. Again, exactly what time point is that going to be most beneficial is not clear. So that's why, the White House held this briefing to say, hey, let's start planning, because the logistics are complicated. Let's start planning because, as you already mentioned, there is some indications that about that 8-month time point after completion of a vaccination series, that might be when we're going to get the most bang for the buck, or that's going to be where we're going to want to offer that. But it's really not fully clear. So there will be an independent evaluation by FDA, and then the Advisory Committee on Immunization Practices, or the ACIP, also has to meet, discuss, look at all of the data comprehensively, and provide a clear recommendation on the exact timing of when should that booster dose, if it is offered, what's the right timing for it. And I wish I had a more concrete answer, but we are literally learning as we go along through this pandemic. And Dr. Panahone, did I leave room for you? Do you want to add anything?
I think the only thing I want to add is that our team is preparing for it, to see what hospitals, what clinics, what other people can help out with this effort. And just another appeal to all the providers, like any providers who want to become a vaccine provider, this is the time to do it, because it'd be so great if you guys could vaccinate your own patients. And I think that's really what a lot of patients want, is like they trust their provider. They'd love to get a vaccine from their provider. So if you are, we have takecarenewmexico.org. You just sign up, and we're trying to make it easier for you guys to get on board. So just a little appeal there.
Yeah, and I have one last appeal too to everyone, and that is, it is safe, as Laura said, to get the COVID vaccine with other vaccines, and that will include this fall's flu shot. And so we're hoping to take advantage of fall flu shot clinics that are given all over the state by DOH, by providers, to move the COVID booster vaccine into those clinics as much as we can as well. So we stand by, we're reaching out to providers. If you're hearing this and would like to have someone come to your office, and we can train you to do what you need to do. It's really not that hard to administer the vaccines, and we'll be happy to work with you to set that up. But I think for me, I'm hoping that I can get my, flu shot, and if this booster does prove to be the thing that will be effective, I can get them both at once in my provider office. And I know people say, I'm having trouble just getting in to see my primary care doctor, but this would allow you in a flu shot clinic at their office to get, the flu shot and the COVID shot without having to have an official appointment. A lot of the folks around the state just get both at the same time. So we're hoping that will really help us out in this next round. Thanks.
Thank you, everyone. Okay, next we'll turn to Morgan Lee, followed then by Julia Goldberg, followed, I believe, by Matt Grubbs. It looks like your hand's up for a second time. Morgan, you are free to ask your question.
Hi, thanks for this opportunity. I wondered if Dr. Scrace, if you could, and I put this up in the chat, if you could comment on whether you're confident that you're getting a good assessment of community spread in the schools, given some low levels of surveillance testing. And the only additional question was just that equation you painted in the southeast of the state with 45% adult vaccination rate. I just guess, I mean, what's the end game? How do you see things playing out down there? Just, yeah.
Okay, I'm going to start with the Southeast first, because I texted the Secretary of Public Education with your question and took a screenshot of the chat there, and I haven't heard back from him, but I'm guessing I might not. But on the Southeast, we are starting to see that same deceleration in the Southeast that we're seeing statewide. And so we're really, really hoping that we see that curve begin to flatten soon. I know they've done a great job down there giving monoclonal antibody treatment to people who are positive with symptoms and risk factors. Again, being over the age of 64, being obese, or one of the high-risk conditions for COVID. And so they're calling because they're running out of IV tubing and things like that, and we're sending them more supplies. So seems like they're doing a good job. I think in the end, though, the pandemic will continue amongst the unvaccinated for a long time. And I don't know exactly how long that's going to be, but I expect to see us having this very, very steady flow of cases. You know, I got my fingers crossed here right now. I want to say 50 to 75 a day. That'd be heaven for all of us who've been working on the pandemic for a really long period of time, kind of like we were in June. And but I think we'll continue to see that, and as new variants come through, I think that there'll be some fairly, you know, again, new mini pandemics among the you know, unvaccinated as well. On the school testing, it's a really good question. I don't know the exact answer. One of the guys, our chief medical officer at DOH, Tom Massaro, just finalized a contract with a testing vendor that specifically specializes in schools. They're going to go to the schools. They're going to do this testing. They start next week, and we'll get more information on that. Laura, unless you know anything more, I haven't talked to Tom in a couple of days. I did see some emails about it, and I'll turn it over to you because I see you nodding your head, which is
Oh, no, I was just nodding my head to say, yeah, they're going to start next week. And so that'll be available to all schools, and it's free as part of the funding that we're getting from the CDC to help testing the schools. So I think that'll also relieve some of the burden on the other testing sites, and will allow us to do more testing of the school kids.
Yeah, but Morgan is right from a mathematical point of view. When you see that testing positivity go up in any group at all, it means that we need to do more testing. We may be missing cases. And so I think your spin on that is exactly right. Like, in order to be confident that we're really knowing what's going on in schools, we do need more testing. And I think that this also, remember, like, no kid should be in school if they have symptoms, right? You parents out there, you're all keeping your kids home no matter what, right? Runny nose, new runny nose, you're keeping your kid home. Bellyache, you're keeping your kid home. You need to do that. And so I think there's a big role for parents in this as well, in doing the testing right away. And a lot of these cases in kids last 2 or 3 days, their symptoms get better. They can go, and if you send them right back to school, they may still be infectious for a couple of days more. And so we really want to make sure we're being careful about that and testing more. I don't know, Christine, anything to add to that on the run out?
Well, I think you just added the point that I wanted to add, is that, you know, there's a difference between surveillance testing or screening, right? These are asymptomatic individuals that we hope to pick up early. But if someone has symptoms, that's diagnostic testing, and that's, we should be seeking a test in any available location that we can. But really the critical message Secretary Scrace just said, if a child is symptomatic, the child should not be coming to school. Of course, we want to confirm what that illness is, and we want to find out if this is COVID-19. But if a child has symptoms or a teacher has symptoms, similar to the publication of the outbreak investigation that I shared from Marin, California, we're all in this together. People need to stay home. The other thing I wanted to add is the FDA has authorized or approved over-the-counter COVID-19 tests. So of course this isn't ideal because this means you have to go and purchase the test. But these are antigen tests. I hope that they're available at pharmacies. I haven't gone in and assessed the stock myself, but I do just want to mention that if a child is symptomatic and you do an over-the-counter test, we're going to consider that symptomatic child positive. If it comes out positive on that test, we're going to consider that. We want the parent to consider that as highly likely as to be COVID-19, and we want that child to stay at home. We would love to see that over-the-counter test is confirmed within, say, a 2-day period by a PCR test or a lab-based test. That's what we're advising. But this is another tool that is available. So I just want to mention that these are approved and should be available at pharmacies.
And I did actually, in late breaking news, Kurt Steinhaus, our PED secretary, did just text me back here. I guess you can't read it, but it says, most schools are meeting state goals for staff surveillance testing. School districts not meeting the goals are receiving technical assistance and additional options for testing. Weekly warnings and reminders are sent as well. So they're on it. I do think the new testing vendor will help. And I think the thing, to get back to the couple people who brought up the issue about access to testing, we have really dramatically increased testing recommendations in the state recently. First, we have a huge surge of cases. We always see testing go up. But now we have employees who are unvaccinated who need weekly testing. We have more rigorous regular testing in schools and congregate settings and commercial, other commercial settings. And so there is pressure there, and we're working as fast as we can. Again, to the extent that surveillance testing you can do at home, kind of by UPS, it's still free. We really encourage that if you're one of those people who needs a weekly test, although you could also get vaccinated and avoid that weekly test. And so it's like the funnel. There's an awful lot of testing coming through this spot, and we are doing everything we can to widen it, including offloading or prioritizing surveillance testing to other vendors, like we just talked about with schools. So I didn't mean to minimize that, since people have of some frustration out there getting the tests. And I'm hoping in the next week or two, we'll be able to reroute these tests in a way that will make it easier for everyone to get tested.
Thanks, everyone. I see 3 members of the press with their hands raised. So unless others choose to raise their hands, I think these will be our last 3 questions. I see Julia, Matt Grubbs, and Brittany Costello. So we'll go in that order. And Julia, you are unmuted.
Thanks, Matt. This also is a follow-up on the testing question. I understand the health department's recommendations as it relates to surveillance testing for people who are unvaccinated. I wondered if you could talk at all about what might be best practices for the increasing number of venues and events that are also requiring either proof of vaccination or proof of test, because I'm seeing a really wide variety. We have a few venues in Santa Fe that say if it's a rapid test, it needs to be less than 6 hours old. and clinically verified. I haven't quite figured out how they came up with that number or if that number is meaningful. And I'm also curious if antigen testing seems to you useful in a non-surveillance capacity. I was told by a DOH tech that it is not, but I haven't had anyone else tell me that. So those are hopefully clear in my question. Thanks.
Yeah, I'm going to start with the large event topic, and then I'm going to let my esteemed colleagues handle the second question. I was recently visiting some grandkids in San Francisco, N95 goggles on the plane. I always joke that I take 3 rolls of saran wrap and wrap my whole body, but that's not really true. Don't take my mask off. Plane travel did seem safer than the last time, but still makes me pretty nervous. And we went out to eat in San Francisco to an outdoor restaurant where, unbeknownst to me, I was required to produce my vaccine record and some ID. So everybody else had theirs. Mine was in my briefcase. I don't usually take my briefcase to dinner, so drove back home really quickly. It was only 5 minutes away, got my necessary stuff, showed my vaccine card, showed my ID. They were kicking people out. They were not seating people who did not show that. So that was one city's way. And as you know, I'm kind of a fan of local interventions to try to control outbreaks. It was one city's way of doing the best they could to stimulate the economy, keep people in restaurants, but minimize risk to patrons and particularly servers who, they're pretty high risk when they see so many people in a day without their masks on. I think with the state fair, there's been vaccine requirements put in place by the public health order, certainly only allowing vaccinated people into an event significantly reduces the probability of the virus jumping from one person to another person to another person. That's one way to do it. Recent testing, almost anything you do that divides people into 2 groups, high risk and low risk, will help. And if you do 4 things to divide people into 4 consecutive things, you'll end up with a pretty safe sort of event. Now, to be practical, you can't require anyone who wants to go to the state fair to not have any human contact for 2 weeks before they come, but that would really decrease the chances of spread of the virus. And so I think the answer in situations like this is to chain together things that dramatically reduce risk. So vaccination or recent tests.
Just 6
Required
hours.
Required mask wearing on the part of everybody at all events, at all times. And like in those classrooms where the teacher's taking their mask off to read, like, don't let that happen, et cetera, et cetera. I don't think we don't have good research data to show what the magic combination is, but I think the more of those things you do all at one time, 6-foot distancing of people at a concert, for example, the more you do, the more likely you are to create a safe environment, even with larger numbers of people.
But Dr. Scrace, would a rapid test within 6 hours be of any more use than a rapid test within 24 hours or 72 hours?
Yeah, I mean, in theory, particularly with rapid tests, they've shown that, like, if you're negative on the first day, like if you take 1,000 people who have COVID and you give them all a rapid test, a certain percent of them will be positive. I don't know the numbers on this. Maybe Christine or Laura can fill in. A certain percent will be positive on the first day, but the next day, the people who are negative, a lot higher percent will be positive, and the next day, a lot higher. 6 hours seems like it could strain some level of practicality, although events that are serious about that could set up a booth and simply do the rapid testing there and, have people wait until they got their results to come in. So anyway, I know Laura is a big fan of rapid testing. There's still a debate about its utility as a surveillance. There's some good data we presented a couple of weeks ago about effective use in nursing homes of rapid testing, even in asymptomatic people. Usually the more confined the environment, the better. But I'm going to turn it over to Laura and then Christine for comments on either of those questions. Mute.
Yeah, I am like David said, I am a fan of the rapid testing, primarily because you can take people out immediately who are positive, and it's very sensitive to being able to pick up if you're symptomatic. But even if you're asymptomatic, it's really a really great test for just for those kind of events. And I love David's idea of like, hey, why don't they just set up a booth? And if they're really serious about it, test everybody, and then you can really get the people who are going to spread, taken out of the system. We did that with the homeless shelters, and we had incredible response. We just limited our outbreaks by like 80% doing that. And I believe that's similar to long-term care facilities. So yeah, like David said, like the more things you do to decrease your risk, the better. And I do think that that rapid antigen test is one of those ways to do it. And like Christine says, you can just buy them over the counter. And so if you want to be extra safe, you can test yourself. It's like $23, I think, for 2 tests. And you can just do it at home. So yeah, I don't know if Christine.
This can be like point and counterpoint, Christine.
Yeah, Christine can counterpoint me, but
You don't have to agree when the issue is controversial.
No, I would just say, Julia, I don't know where the 6 hours comes from. I have no idea. So I don't know. I don't think there's any data on that. I do think testing is another additional measure, but any sort of large capacity venue, the most effective things to stop person-to-person transmission is going to be, of course, promoting vaccination prior to the event, and then distancing, masking, etc. I think that when you're in areas of substantial or really high levels of transmission, even doing a symptom check at the door, if it could be done, very respectfully, also would be quite useful. So if someone has a fever or symptoms, we don't want you to come into this big crowded venue. So I think that one there is some evidence behind that one, but I'm sorry, the 6 hours I haven't heard of that.
I do remember though, Christine, in that CDC report about the, it might not have been in the report itself, it might have been a news story about the report. There was a performer there who was doing live performances, and it did make reference to the fact that he was literally doing antigen tests on himself every 6 hours because he was concerned about not infecting others. And so that's the only place I've seen that number. And
and I think the 6 hours, I mean, I don't know, you can choose any close number you can, but I think really it just has to do with like, it's closer, like 72 hours, it just doesn't pick it up, right? But like the antigen test is really good to pick up like you have COVID right now. And so I think they're just trying to make it be as close as possible. But like if they really want to do it, just open up the little booth next to the venue, because that's how we would, that's how we actually used to work with people experiencing homelessness to get into the shelter. We would test a certain percent, and we just know like, oh yeah, you're already COVID positive. We know now that whole bus is COVID positive, so I mean, not COVID, has more risk, right? So I think that's where the 6 hours come from. I think it's probably just closer to the event, because that's what that test is good for, right? It's good for like identifying you close to the time you have COVID.
Thank you.
All right, thanks very
I
much.
think to sum up, Matt, we're not really sure.
All right, we'll turn to Matt Grubbs, followed by Brittany Costello. Matt, you are unmuted.
Thanks, Matt, and thanks for the second go round. Just in the interest of being expedient, I have a couple here. There seems to be a persistent 9 to 10% gap between the first and second dose numbers that you're reporting. I'm wondering if you expect that to close, or is there a certain level of people who are just going to get one and call it a day? And then my second question is on what I believe was the second to last slide that Dr. Ross, you showed. The narrative around COVID has been that it affects old people, right? It seemed to show, if I was looking at that correctly, and maybe I wasn't, but it seemed to show that since February, kids age 5 to 17 make up a larger portion of the positive cases that you're reporting. I just wanted to know if that's correct and if you could circle back and talk about that. Thank you.
So Laura, I'll bring up my screen of the vaccine dashboard currently, and I can move it around. And then Brianna, if you can be ready to bring up the slide that Matt just mentioned, but here's the vaccine dashboard updated today. And he's talking about the difference between these two numbers, which has actually run about 10%.
Yeah, and that's kind of been that way the whole time. That's pretty consistent with what's been shown nationally too. There seems to be just like 8 to 10% of people that for some reason aren't going back for their second dose. And we tried like a lot of different things like incentives and different ways to get people the second dose, explaining to people that sometimes the second dose has more side effects, but it's still, doing its job. But yeah, for some reason we've seen that consistently throughout the pandemic. And I would guess, I thought something that was really interesting is that when we tried to incentivize that second dose, we did have some increase, but not as much as we thought we would. And it didn't seem to bridge that gap as much as we thought we, could. So.
Laura, I just have one more comment, and that is that, remember, Matt, this is not a fixed point in time. So we won't know for sure what this gap will be for another 4 weeks, right? Because a bunch of these folks, a large number actually, got this new one dose in the last 4 weeks. And so, I'm kind of hoping it ends up settling down at about 5 to 6% once we get the catch up. And, we have a ways to go with kids here, and where the gap is a little bit bigger, but again, much more frequently vaccinated of late. And so, and then Laura mentioned the incentives, and we did show a month over month increase of 25% in first and second shots, in addition to giving about, I think, 6,200 of the third shot, the third shots for people with immune deficiency. Christine, do you want to talk about the other question?
Sure. So I don't know if you want to pull the slide up again. So I make sure I'm looking at the right slide.
He said the second to last one.
Okay. So
just a moment here, sorry.
So I think just to give some context, I think overall New Mexico has done a really good job at rolling out testing. When you compare, look back through the course of the pandemic, compare our testing rates to other states. We've done really well when you compare us. We haven't tested children as often or at as similar rates as adults. So burden among children, we believe, some of this burden we're not seeing. We're not testing all these kids with really mild symptoms. We know kids are getting a new virus every other day in normal times. And with COVID, we know that they can have asymptomatic or really mild disease. So we know that just in general, we don't test pediatric age groups as much as we test adults. With that being said, I think we could pull up the pediatric report, but I think pediatric age groups have made up about 15% of our overall cases. Currently, they're about 25%, if I'm remembering correctly, of what we're seeing now. So they are a bigger proportion. And then I think the slide might have been before this one, Brianna. So it was just showing, I think we pointed out that increasing trend in the 5 to 17-year-olds, which I believe you mentioned. So that was the yellow line, and just showing that is a larger percentage or proportion of our total cases, and case rates are quite high in that age group. But if you're looking at absolute numbers, still the largest number of cases is in the 35 to 64-year-old age group, which is the pink line, and then followed by the 18 to 34-year-olds. But given those high case rates that we're seeing in the younger age group, you can see they're sort of taking up, they are taking up a larger proportion of the total cases over time. And that's what we were pointing out in that graph. I think that was the slide that you were referring to.
Yeah, let me add one thing, because Matt, you made another good point about, we think of COVID as a disease of the elderly, but if you look at that green line, you know, go all the way back to the left, Brianna. When it first started, maybe through June of 2020, it was kind of a disease of the elderly, but it dropped really fast. And I call people 65 and older my people because I'm a geriatrician, but we've hunkered down, and they are taking precautions, wearing masks. They're the ones who write us notes about how we need to have a mask mandate when we don't, and they're being pretty careful. And so that observation that COVID was a disease of the elderly was true for a couple months, but it no longer is true at all. And then this summer we saw that emergence of the 18 to 34-year-olds. It was actually last fall, and we've seen those two groups on top ever since. So we should put that one away, because it's now it's really 18 to 64-year-olds, that sort of middle, young, older young adults and younger middle-aged folks and middle-aged folks who are 70% of the cases there, or 2/3 anyway. Thanks. Any more there, Matt?
Yep, one final question from Brittany Costello. Brittany, you are unmuted.
Hi guys, thanks again. This will be super quick. I just wanted to circle back to last week when you guys had mentioned the ICU waiting list. So according to the slides, it looked like as of yesterday, there were some beds there, but I'm just wondering, is that list still a thing, or are those people kind of placed?
Yeah, the people that were on it last week are pretty much placed. I think we're in the range of 10. See, the state operates a call center. Hospitals themselves can't refuse admissions if they have open beds. They can't do waiting lists, but the state operates this call center, which gives us some flexibility. And so we can actually manage all the beds in the state like it was one really, really large hospital. So we're down quite a bit. We do, when we get calls, we know that we're going to be able to place people later in the day. So we have a smaller list, but we're still have one patient for every ICU bed we have right now, plus a few more, but better than last week.
Okay, I think that covers all of our questions. Any final words from our panelists?
Go ahead, Laura, Christine, and I'll close. Unmute, Laura.
Got that, sorry. Sorry, my final word is really to the parents of children who are 12 to 17 years old, to really get them vaccinated, because they are, the least vaccinated group, and just that way we can protect them. These children still can get really sick from COVID. They can actually even get long-term COVID. So if we have something to prevent them getting from sick, go ahead and get the vaccine. Get your answers to your questions, talk to your provider, talk to people you trust, so you can get your questions answered, and really make that decision that is informed, and you can feel good about vaccinating your children. So thank you so much for having us again today, and thanks to everybody here.
Okay, I'll follow on that. I just want to also encourage my fellow parents to opt in to surveillance testing that is associated with schools. My understanding is that this will be mandatory for unvaccinated teachers, but students will be allowed to opt in. So I just want to really highly encourage you to consider opting your child in for this surveillance testing, and then of course, seeking out a diagnostic test whenever your child has symptoms. But while there is this the period when symptoms develop and we're trying to confirm what that diagnosis is, that symptomatic child should stay home. It's just really critical. We need everybody to do their part so that we can keep transmission down as low as possible at the school environment and have a much better school year this year than we had last year. So thank you.
Yeah, and I just want to again thank our media partners. The level of sophistication of the questions keeps going up every week. You're really keeping us on our toes and asking about correlations between page 7 of one epidemiology report and page 3 of another. And so these are really great questions. You know, when I think about the first couple of weeks we did these press conferences, and I was really wanting to make sure I spelled COVID correctly to where we are today, the kind of data we have, the ability to track it, and you all just challenging us every week to do more, that really makes the job satisfying over what's been a really long haul. I think you might remember I predicted this might be over on September 30th of this year. So we only have 29 days left for that. But I would just echo my colleagues today, get tested, you know, be careful, wear your mask, keep your hands clean. And above all, really, if you're still not convinced about getting vaccinated after the excellent data Laura showed today about dispelling these myths and this pandemic we're seeing in the state, which is really only, for the most part, amongst unvaccinated people, at least from the hospital perspective, it's almost exclusively unvaccinated people. Please have one more discussion with your trusted healthcare provider. Last, if you get a positive COVID test, you're over 64, significantly overweight, or have one of those risk factors for more serious COVID disease that could put you in the hospital, please seek out monoclonal antibody treatment right away. The sooner you can get it, the better. Positive test and symptoms and then risk factors means you should be treated. So with that, I think we're going to thank you all, and probably we'll see you again next week. I'm kind of hoping we can go back at some point to every 2 weeks, but as you saw this week, we've had plenty to talk about and filled up almost 2 hours. So we'll keep up the frequency according to the data and your interest and your questions. And with that, Matt, I'll send it back to you one last time.
Thanks very much. Yep, we'll be back with everyone with an advisory next Tuesday, inviting you to the Wednesday press conference. In the meantime, we're here to answer your inquiries all week long. David Morgan is your primary point of contact, but you've got a whole DOH comms team to support him as well. So thanks everybody, and we'll see you very soon.